So what's new in treatment for metastatic breast cancer? I'm going to give you molecular biology 101. I'm then going to talk to you about CDK inhibitors because many of you in the room are on CDK inhibitors, and I'm going to give you an update. And I'm going to give you a little bit more information about immunotherapy because unfortunately, with the advances that immunotherapy has made for other cancers, particularly melanoma, lung cancer, there has been a bit of an overwhelming community sort of response to immunotherapy is the drug for the future, and therefore, for breast cancer patients, this is the area that we want to go into. Yes and no. It's all about biology. Okay, so this is a cartoon of the nucleus that I showed you a real picture of. That's the cell it sits in. That's the surface of the cell. And remember, this isn't a two-dimensional picture, but it's a three-dimensional organ. And on it are a number of self-surface proteins. Some of the proteins are little divots, like little doors into the cell. Others just sit there waiting to be activated to do its job. And what does it do? The simplest way I can describe this is that every cell, and this includes your normal cell, but obviously our talk is focused on breast cancer cells, will have the ability for something sitting outside the cell, which is called a signaling molecule, make contact with one of these self-surface entities, whether it be a receptor or one of these little protein blobs that sit on the outside. On making contact, it changes that protein on its surface. And essentially, if it's going to help that cell to grow, it will either internalize and move the whole thing into the cell, or it starts a cascade of reactions, a little bit like an atomic reaction. And as it goes down into the cell, heading towards the nucleus, these steps all sequentially go towards inciting the nucleus of the cell to grow. That's breast cancer in a nutshell. One of my patients showed me a picture that she'd been given, and this is pertinent to breast cancer. So this is specifically, and it's really, as she said to me, it's a bit like an electrical board. And that's how you've got to think of it. So the first slide I just showed you then was a single line signaling pathway. But within your cancer cell, and that's why these cells are so complex, so difficult to treat uniformly, is that you may start off with one of the receptors being excited. It talks to molecules inside the cell, and it goes down this cascade to stimulating your nucleus of your cancer to grow. But in the meantime, as all of this is happening, there are other circuitry in your cancer cell that speaks into it to either hype it up or in some instances slow it down. At the same time, as this cascade is going on, the cascade incites other circuitry to get hyped up. So these circuitry may not have been excited by something on the surface, but the inside circuitry excites neighborhood circuitry. And this is a dynamic process. It's going on every single second of your life. And some of these pathways tell the cancer to stop. Some of these pathways say, hey, let's get some of the immune system in your body to come and help the cancer cell grow. Some of the signals incite your immune cells to come and help it kill the cancer. Some of these circuitry tells the blood vessels around the cancer cell to grow faster, to supply more oxygen and nutrients to the cancer. And then we are also understanding that even the supportive tissue around the cancer cell can be impacted on by the circuitry within the cancer cell. And it's all changing the environment to help make the cancer easier to survive, easier to grow, easier to spread, easier to get into the bloodstream. So this is what we're dealing with. And specifically for breast cancer, I think many of you will be familiar with some of these terms, HER2, estrogen receptor. And just to give you a sort of a summary, probably the most important proteins, receptors, and pathways that we utilize to treat your cancer are the ones that I've indicated there. Some are on the surface, some are on the surface and get internalized. Some of the treatment, specifically the CDK inhibitors, work here at the nucleus level, and there are other drugs that target other things in the middle. And what are those drugs? These are the key players. So some of you are on these drugs, some of you will have heard of these drugs, But essentially, all those drugs that I've shown you in the orange splash are the drugs that work at different points in that cell growth to try and make the cell stop growing. So it's really, really ingenious. And at this point, I'll just put in a plug for evidence-based medicine. It has taken 10, 20, 30 years of thousands and thousands of scientists and clinicians and pharmaceutical companies and research centers to get to this kind of level. There is not even a 1% comparison with complementary therapies. So although complementary therapies, are said to cost, I think, more than $5 billion a year in terms of what people pay in Australia, there is not even an inkling of this degree of finesse of scientific research that supports the use of the vast bulk of complementary therapies. So very specifically, for the CDK inhibitors, because these are exactly the group of drugs that has been researched and developed based on our understanding of molecular biology. And so just to tell you, because I do get asked, how do CDK inhibitors work? Many of you may not care, but seeing I have been asked this and I was asked to speak about this too, I'll just spend a couple of minutes on this. So the CDK protein kinases and the cyclin proteins are very, very important in making the nucleus of the cell grow. So this picture, where it says it's starting from G1 through to M, is growth phase, synthetic phase, mitotic phase, and then the cell doubles. So what happens is that the CDK proteins and the cyclin proteins are very, very important in allowing this to happen in a circular fashion. And an important component of that is a protein called the retinoblastoma protein. And so the finding of this was that if we could interrupt the complexing of cyclin D with particularly cyclin D kinase 4 and 6, because these are really important guys in breast cancer, you can actually interrupt this and make the cancer cell die. And before I move on to talking about CDK inhibitors, I just want to give you a few terms, because I think there's been a little bit of, social media as well as marketing to inform the community that CDK inhibitors now, for a few of the trials, have actually proven to show an overall survival benefit. And many of you know that any drug that can actually improve the overall survival of a stage 4 breast cancer gets a lot of attention. But I just want to give you a little bit of teaching about the terminology, because when drugs are evaluated for stage 4 breast cancer, almost uniformly, the first outcome that we want to measure for that new drug is called PFS, progression-free survival. What does that mean? It means how long can that drug keep the patient alive without the cancer progressing. So from time point 1, you start the drug. At the point you die, that's your PFS. At the point the cancer grows and starts spreading or getting bigger, that's your PFS. All right? Now, you can probably estimate that if you have a drug that can prolong a woman's PFS, it's likely to prolong her overall survival. Not always, because one of the beauties about stage 4 breast cancer, which I find is what keeps me going all the time, is that there are a number of drugs beyond the first treatment. So if a woman's had a good response to the first drug and it's no longer working, there's usually a number of drugs I have in my armamentarium to offer that patient. So if you only measure what the PFS of that patient's survival is with drug 1, you can't basically account for what the effects of drug 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11 are, because that's what's going to impact on the overall survival of that patient. Overall survival is pretty obvious. It's from the time point you measure the person's alive to the time point you measure that they're dead. When we report results, we don't report average. And it's a really important distinction, because this should give you a lot of confidence. An average means that if you have 100 patients and they have each lived a certain number of months, you add up all those months that they all collectively lived and you divide it by 100. The median, which is what we generally report in cancer, including other cancers beyond breast cancer, is how long does the 50th percent patient live for? So you may find that out of 100 women, 49 will live for 12 months. The 50th person lives for 12 and a half months. And then the next 49 can live for 13 months to 13 years. And that's much more important information than averaging it out. All right, so when you see a result, if your oncologist recommends for you to have a drug because it's improved the median survival, it's actually more meaningful information for you than saying it improved the average survival. The next thing, if you are interested in looking at papers, and I know many of you access the internet, but I'm feeling confident that those of you who I've got to have not been accessing Dr. Google as much. Because as I've said to you before, he never got a medical degree. If you're going to look at results where there is a 95% confidence interval given to you, what it means is that they've told you for that drug treatment what the median survival is, 12 months, and then in the brackets after that where they say the 95% confidence interval, it's the number of months where they can confidently tell you that 95% of those women in that trial would have lived for. So if you have a median survival of 12 months and the confidence interval is 11 months to 15 months, you know that the data is really tight and it's really quite believable. If you have a median survival of 12 months and the 95th confidence interval is 2 weeks to 20 months, it means that the results are still believable, but this drug works very differently in different patients. So it absolutely does nothing much for some, but it does a lot for the other end, but it still ends up giving the same median. Okay? So what are the cyclin D kinase inhibitors in metastatic breast cancer? These are the pivotal trials that led to these drugs being approved in many countries. And all I really want to point out to you is, and this is an important point because it's relevant for some of you in the audience, is that essentially the trials uniformly showed that when you combine one of the cyclin D kinase inhibitors with an aromatase inhibitor, so that is letrozole, anastrozole, or exemestane, you basically doubled the woman's progression-free survival. This included younger women, because in younger women, they can't just have an aromatase inhibitor. Younger women have to have the ovaries blocked with something called a GnRH, and then they get onto an aromatase inhibitor. A number of studies have also combined cyclin D kinase inhibitors with another hormone drug called fulvestrant. And again, you can see that the improvement is very similar to that when cyclin D kinases were included with an aromatase inhibitor. But in women who were entered into this trial, they actually got into this trial because their cancer had already progressed on an aromatase inhibitor by itself. And I'll talk to you about what the relevance of these results are for women in Australia in a minute. Thirdly, there is one cyclin D kinase inhibitor which has just gone onto the PBS 3 weeks ago, so that's a pleasing result, which showed that if you use it just by itself without any hormone partners, it can also improve outcomes. So what's new? For those of you who have a photographic memory from last year, this is now CDK inhibitors in 2020. And the new thing is that all three cyclin D kinase inhibitors are now available in Australia. So that is ribociclib, palbociclib, and abemaciclib. However, you will only get access to that and have Medicare pay for it if one of those three drugs is combined with letrozole or anastrozole. So, can women access cyclin D inhibitors if they've already received a hormone drug in the first-line setting? Essentially, no, unless the first drug you got in the metastatic setting was tamoxifen. So if you've already received one of these letrozole, anastrozole, or exemestane, and you then want to get onto CDK inhibitors, you can't access it on the PBS. You can pay for it. It's roughly $33,000. and if you can afford that and get the benefits from that, there is now an access program that will provide the drug for you for free after that first 8 months or so. And these drugs are so exciting and so effective that they are now being evaluated in other types of breast cancers. So currently they're only available for women whose cancers are hormone positive, HER2 negative, but there are a number of studies now being done in hormone positive, HER2 positive breast cancer, and there are now nearly over 10,000 women that will be ultimately recruited to early breast cancer trials. And we're really excited because we've been involved in all 3 of these trials. So I have no doubts in a couple of years when we talk about this a family of drugs, we're going to know that a number of women in Australia, and particularly those that have been treated by us, will have benefited from higher cure rates because they were involved in these trials. So I'm just going to show you what the difference is. So this is one of those trials that showed that there was a improvement in progression-free survival. So the blue line are all the women in the trial that got palbociclib and letrozole. The women in the trial, and this is about a 666 patient trial, got just letrozole and a placebo. So if you look at the median survival of the women who only got letrozole, it's about 13 and a half months. If you look at the women who got the palbociclib and letrozole, it's sitting out here beyond 2 years. But look at this, there are still women responding beyond that. And the reason why each of these curves have got these little vertical lines is that although this particular woman only did well up until 6 months, it isn't meaning to say that other women in that group didn't do better longer because they've only been on the drug for 6 months. So the little vertical lines tell you how women who are still on the drug are faring, but we don't know whether they're going to live longer and do better because they actually haven't been on the drug for that long. That's what that curve means. This is the overall survival curve of one of the trials, and this is with the drug ribociclib. So the overall survival, median survival for the women who didn't get the ribociclib and only got fulvestrant is about 3 and a bit years. For those who got ribociclib and fulvestrant, they haven't actually reached the median survival. How encouraging is that? So you may all be thinking, why can't we access this combination of the PBS? Excellent question. Write to your local members. Are there any questions? Not just maybe of CTK inhibitors, but anything on the biology. Yeah. Good question. So the question was, there are a lot of clinical trials investing into women in the first line setting, but very, very few second, third, fourth, fifth line. And that's a really good question, and I'll give you my honest answer to that. The first thing is that once you've got a group of women who have received treatment and their cancer has progressed, it is actually technically very difficult to get a what we call homogeneous or very similar group of women so that you can test a second drug. Because if you have a group of women who have received type A and a couple of those responded to type A for 5 years before the cancer progressed, put those women into a second line trial, and then you've got a few women who've been on the same drug and the cancer grew on that drug after 6 weeks, you put them into a trial for a second drug, you kind of expect you're going to get a different response in the second line setting. So it becomes very technically difficult at any one time point, at any one institution, or even if it's a multi-center international trial, to get women all very similarly treated in the first line setting to evaluate a second drug. But clearly, the fulvestrant story, they did that. They actually had a whole group of women who had only received an aromatase inhibitor. They involved a lot of centers around the world, a lot of expense, a lot of work, and they actually collected a group of women, a few hundred, that were all treated very similarly in the first line so they could evaluate in the second line. If you then have a group of women in the second line who've now progressed and they need a third treatment, it's getting progressively harder and harder to find a homogeneous group of patients. So that's probably one of the most important things. The second thing, and it may come from cynicism because I've been doing this for so long, is that pharmaceutical companies invest a lot of money in trying to prove that their drugs work, but they want to go with where the money's going to be. So if it's going to be harder to prove that their drug works, they are going to be less likely to invest the money and the time and the effort into that. So how about non-pharmaceutical researchers? Yes, we can do that, but you will find almost nobody in Australia, a few people in the States, but it's a conflict of interest. There are going to be no clinical oncologists who are going to be responsible for patenting a new drug to then be responsible for evaluating that new drug. So there's a sort of a mismatch in the ability to create a new drug and then finding the population of patients and the hospitals to do that trial in. But I think, that isn't the end of the story. And I think that's something that's really, really important in terms of collecting data, as was the earlier question. Because if you have institutions that collect data on what happens to their patients after the first line, second line, third line, fourth line, you actually get a picture of what works and what doesn't work. So we're going to be publishing our study hopefully by next year. And that is one of the big questions that we're going to be actually addressing in that. Okay, so a little bit is practical. Palbociclib was the one that was first approved in Australia, and so that's the first one. Ribociclib came about only last year, and abemaciclib only got approved 3 weeks ago. So essentially, it's a really good question because that's what pharmaceutical companies ask all the time, with the implication, how can we make oncologists use our CDK inhibitor? And essentially, when I give talks, I say to people, you've got to look at the patient. Each of these 3 CDK inhibitors have slightly different side effect profiles. They have got slightly different scheduling of medications, and there's a slightly different way of following up side effects of these drugs. So what I do is I look at my patient, I look at what side effects and symptoms she already has had. I look at whether she has other health issues, particularly cardiac, because ribociclib has a very, very small possibility of affecting heart rhythm, although it's getting increasingly rare for this to be seen. And I also ask patients, having said, these are the side effects of drug A and drug B, some will say to me, Arlene, I've had so many problems with infections in the past. I really want to have the CDK inhibitor that is going to have the lowest chance of, lowering my white cell count. So palbociclib tends to lower your white cell count more than ribociclib. So I think there may come a time when all these 3 drugs are on the market that someone is brave enough to do a head-to-head comparison. But that isn't going to happen anytime soon. And so a lot of the actual clinical utility is really based on your knowledge, and really oncologists need to know the ins and outs of all 3 drugs in all 3 trials so they can actually make the best decision for their patient. Okay, so immunotherapy. This is a picture of how cancer can involve your immune system for its own benefit, and then I'm going to show you how immunotherapies work. So cancer cells can actually release proteins, and these proteins incite your own immune cells to help it. In the process of the cancer cells creating these proteins, they need your own cells to present these proteins to your lymph nodes that make the immune cells to help it. So there's actually a potential point here that as a therapeutic intervention we could interfere with. Once the cancer cell has made your immune cells primed, these cells then go out and they can prime other cells to help it encourage your cancer cell to grow. But sometimes along the way, this immune reaction actually makes your immune cells hyped up, turned on, switched on to kill the cancer. So this is where immunotherapies work for breast cancer. A lot of you probably don't know, but chemotherapy can induce an immune effect. We see this all the time. So chemotherapy has actually been considered that one of the reasons why it can be effective, and particularly more effective in some patients than others, example, triple-negative breast cancer, is that the chemotherapy kills the cancer cell itself, but it also induces and excites your immune function to help the chemotherapy kill your cancer. But clearly, the biggest area of research is with the actual immunotherapies itself. And what these drugs do is they interfere in the process of the immune cells helping the cancer to grow. And that's probably the easiest way of me stating it. Okay, no more pictures. Side effects. I want to squash a myth that immunotherapy is natural, and because it's not chemotherapy, it's really safe and has no side effects, because that's not true. It has different side effects to chemotherapy. Now, I don't want to frighten you all, so this is not meant to be a scary slide. This is meant to be a educational slide, that immunotherapy certainly can have side effects, and it can affect a number of different organs and then produce the symptoms in you. And essentially, the reason why immunotherapy have side effects is that sometimes, unintentionally, the immunotherapy has an impact on your own immune cells to make your immune cells attack a normal organ in your body. So your normal skin cells, the lining of your gut, your lungs, your kidneys, your liver, and even your own immune system can be inadvertently excited by the immunotherapy to damage those particular organs. So people on immunotherapy, and some of you might be on some of my immunotherapy trials, we need to be really carefully monitoring for these sorts of side effects, because sometimes it actually leads to the drug having to be stopped, just as much as chemotherapy needs to be stopped if it's causing too many side effects. And it's really because of this potential for self-damage. The second thing which is really important, particularly for those of you who are on and considering immunotherapies, is this new condition called pseudo-progression. So many of you will be very familiar with the fact that to monitor you, you will be having scans to see whether your cancer spots are getting getting smaller and less dark and so forth. And when things are getting smaller and getting less dark, we're pretty confident the drugs are working. With immunotherapy, there are a number of studies now showing that you can actually have patients responding to the immunotherapy, but the standard way that we measure what's happening to your cancer spots is actually showing that it's progressing. So this is a picture of a patient who started treatment with a cancer spot in the lung that size. 1.5 months later, on immunotherapy, it got bigger. 5 months later, it got bigger again. But we recognized this syndrome, so the patient continued to receive the immunotherapy during all this time. And finally, just short of 9 months, the cancer spot started to shrink. So, many of you will want to ask your oncologist, how big is the spot in the liver? What's happening to the one that's in the left lung? So you've got to be very careful. If you're on immunotherapy, do not be dismayed if your oncologist actually says it's a bit bigger. And we have standard ways of monitoring and making an assessment of whether it's pseudo-progression, which is false progression, or whether it's real progression. So I think my take-home message for immunotherapy for breast cancer, it is, almost certainly going to be a very exciting new class of agents to be used, but really to be reserved for future treatments and currently only involved in clinical trials. And I think it's really important for the community to understand we are going to have very similar issues with immunotherapy as we have had with hormone drugs and chemotherapy, because we've got to decide which breast cancer patients are going to do the best with immunotherapy and therefore should be receiving that. Secondly, how do we access these drugs? They are enormously expensive, and there is not one single immunotherapy drug available on the PBS at the moment for breast cancer. Thirdly, and there is certainly a lot of evidence to support this, is that you will probably get the best bang for your buck with immunotherapy if it's combined with chemotherapy or something else. So please don't be under the impression that once immunotherapy is available, there goes the side effects and the concerns about chemotherapy. Probably won't be the case. And then more importantly is, how do we know it's working? With the pseudo-progression, the length of time it takes for us to know whether things are working well or not. How do we know that we're treating patients correctly? So we've got to do a lot of work on that. And then lastly, we absolutely have to know how to manage side effects. And ideally, we want to be able to stop side effects from occurring rather than allowing things to occur for women to suffer symptoms and then having to be concerned about it. Any questions? So the question was, breast cancer spreads to other organs, and that's why we call it metastatic stage 4 breast cancer. Can it happen in the reverse? It can't happen in the reverse, because if a cancer originates in the liver and then goes into the breast, which never happens, I've never seen a case for that, it's still called liver cancer. Now, I have seen a patient with kidney cancer where the kidney cancer cells went into the breast, but you call that patient kidney cancer with stage 4 metastatic disease in the breast. So the way you define a patient is always, what is the organ of the cell of origin? If it was breast cancer at the beginning, it remains breast cancer no matter which organ it goes into. So, I mean, I know some of you will talk about, my bone cancer is doing this or my liver cancer is doing that, and that's, that doesn't matter. But you don't have bone cancer, you don't have liver cancer. You have breast cancer in the bones, you have breast cancer in the liver. Okay, so what would make a patient ineligible for immunotherapy treatment? At the moment, and again, this is based on research, the groups of women most likely to respond to immunotherapy are those who have triple negative breast cancer. So the cancer cell doesn't respond to hormone treatment, it doesn't respond to Herceptin trastuzumab drugs. And that's because that's the group of women that seem to derive the benefit. So if you've got metastatic breast cancer and yours is ER positive, you won't be eligible for most of the immunotherapy trials at the moment. Having said that, there are trials in early breast cancer, and I mentioned that we're doing one of those, where they're now starting to evaluate immune therapy for ER positive breast cancer. Now, if you have triple negative breast cancer, so you're in the group that immunotherapy might be beneficial for, you still have to fulfill a number of criteria to get into the trials. We've got 3 immunotherapy trials at the moment. One of them requires you to have triple negative breast cancer in the liver. If you don't have it in the liver, you're not eligible because they're asking a specific question. Another one, we think we've just taken the last spot internationally, so I won't talk more about that, but it's been a really effective drug, and I'm hoping to give you some results next year. And we've got a 3rd trial now that, again, is only suitable for triple negative breast cancer patients. But like the earlier question, it's reserved for women in the first-line setting. The company determines that. So the immunotherapy, virtually every drug, I'm just trying to think if there isn't any time a new drug is being evaluated, it will always be initiated by a drug company. Having said that, it's all above board because drug companies don't have access to patients. They're not doctors. So what they have to do is they have to recruit and involve and have breast cancer specialists who know the science and believe that their drug is effective to come aboard to put patients on trials and do the work. So although a drug company funds the drug development, funds the drug trial, it's the doctors, the breast trials unit, the staff, nursing, and patients who actually answer the question whether the drug works or not. The drug company doesn't do that. We do that.